All right, good morning. It is February 28th, the last day of February, and this is Senate Health and Welfare. This morning, we are going to look together at our committee bill that we've been working so hard on and taking testimony about. Just to let folks know, you understand as a committee that we went through. I would please wait, and then again, when we begin, you can go through agenda. I'd like you to listen just for a minute so you understand the process we've been through. And we have been through an extensive process. First, the framework was worked on over the summer and fall. Then the framework was placed on our table and we looked at it with Ledge Council, and then we have taken significant, both expert high-level policy testimony, and we have also taken testimony from folks in the state of Vermont that are going to be affected by this. We've heard from Big Mountain Care Board, Agency of Human Services, a number of folks, and we will, once we go through the bill ourselves and consider it, we'll keep it on the table, and we will have some testimony when we get back after town meeting break, because we need to hear from folks what their thoughts are. I know that there will probably be every person in the state of Vermont will want to respond to this, but that isn't the point. When we make high-level policy, we're going to have to listen to the folks who have representation and represent different communities, regardless of whether they're hospitals or payers or boards or whatever. So we've got a lot of work in front of us, and I want just the goal here is to look at the committee bill with an understanding that we have specific goals, and I tried to enumerate some of those goals as Jen and Martine and I went, Senator Gulick and Jen Carvey and I went through the bill, and then again went through the bill again with Jen fine-tune it. So it's by no means complete. On the other hand, we have done a lot of work. And looking at the goals, I would think overall, first of all, we've been working for years to provide hospital sustainability. So that's one goal. We're looking to improve health outcomes on a population base for our citizens of Vermont. We are looking to improve quality of care. We are most importantly looking to lower cost. We are looking to ensure that our payers maintain solvency, and we can do that in a variety of ways as in the bill. We are looking at setting a goal for regional access to care through planning process. We are looking to improve the way budgeting is done through a total cost of care model. We are looking to integrate our system of care through the planning process. We are looking for care coordination as much as possible. We are looking to increase investments in primary care, home health, long-term care as much as possible, and provide incentives for those things. Overall, this is a bill that we hope will reduce costs, will increase quality outcomes, and provide for population health improvement in the state of Vermont. So it's a lot in this one little bill, but I think we're making a step in the right direction. And so I would like for us to keep an eye on the statewide improvement process that we're looking at. And at the same time, of course, we're each interested in what happens in our own hometown. So we've got a big job in front of us as we review the bill, and we're going to do it. And I know you have invested a great deal of time in this, and I really appreciate it. So Jen, I'm going to ask you to come up and walk through the bill with us, and we'll probably put it up on screen. Well, now you can kind of I would suggest that you wait until Jen explains some of the language, because legislative language sometimes look different from what you think it is. That was my honest comment before.
Jen Carvey for the Office of Legislative Counsel. So we are looking at draft of the committee bill on healthcare reform topics. You can see, because this is a committee bill, I won't do the statement of purpose, which is really the plain language summary, until the bill text has been finalized. So just highlighted that. Titled it, at least for now, an act relating to healthcare payment and delivery system reform. It starts out based on your conversation yesterday. I moved the hospital budgets and payment reform provisions to the beginning. So that was later in the outline, and you asked to move that up front. So it starts out in section 1 by amending the duties of the Green Mountain Care Board, largely to align with other changes that are made as we get into the bill. So the first one, in their existing statute, under their duties, they're supposed to oversee the development and implementation and evaluate the effectiveness of healthcare payment and delivery system reforms. There's more information there, but I'm not changing it. I'm just trying to get you to where we are with implement by rule, methodologies for achieving payment reform and containing costs. The existing language says that may include the participation of Medicare and Medicaid, which I think is accurate, but doesn't specifically say commercial. I think that part is implied. It's hard to add it in there, so it continues to be implied. But I did add reference-based pricing. So may include the creation of healthcare professional cost containment targets. I added reference-based pricing, and then the list goes on: global payments, bundled payments, global budgets, risk-adjusted capitated payments, etc. An existing duty is also to set rates for healthcare professionals pursuant to section 9376, which is where I put the reference-based pricing language, but it says to be implemented over time, and I've added beginning with reference-based pricing in 2025. That is the first piece that you are directing on that. Also, under existing law, they approve, modify, or disapprove requests for health insurance rates under APSA 4062. And there are certain things they're supposed to take into consideration, including changes in payment methods and amounts. And I added including implementation of reference-based pricing. Existing subdivision 7, they review and establish hospital budgets pursuant to chapter 221, subchapter 7, which we will also be amending. And I've added including establishing standards for global hospital budgets that reflect the implementation of reference-based pricing and the total cost of care targets set by the statewide healthcare delivery plan developed pursuant to section 9403, which is a new section coming up later in the bill. And beginning in hospital fiscal year 2028, the board shall establish global hospital budgets for not fewer than 5 Vermont hospitals that are not critical access hospitals. By hospital fiscal year 2030, the board shall establish global hospital budgets for all Vermont hospitals. You can see some more detail on that in the hospital budget section. Section 2 amends 18 VSA section 9376. This is the Green Mountain Care Board rate setting statute. And I've, to start with, just gone in and put what we call subsection headings, because this is about to become a much longer section. So the existing subsections I have not changed, but have labeled as intent, just reflecting what's in them: rate setting, methodologies, and supervision. And then I have added a new subsection E on reference-based pricing. This directs the board to establish reference-based prices that represent the amounts that payers in this state shall pay to healthcare professionals for services delivered to Vermont residents. Purposes of reference-based pricing are to contain costs and to move healthcare professionals toward a site-neutral pricing structure, while also allowing the board to differentiate prices among healthcare professionals based on factors such as demographics, population health in a given hospital service area, and a specific provider's role in Vermont's healthcare system. Directs the board to consult with payers, including health insurers and the Agency of Human Services, on ways to approach reference-based pricing in an effort to achieve all payer alignment on design and implementation of the program. It has reference-based prices established pursuant to this section being based on a percentage of the Medicare reimbursement rate for the same service, provided that after the board establishes initial prices that are referenced to Medicare, the board may opt to update the prices in the future based on a reasonable rate of growth that is separate from Medicare rates in order to provide predictability and consistency for healthcare professionals and payers, and to protect against federal funding pressures that may impact Medicare rates in an unpredictable manner. I'll just pause here for a moment and say, if we peg everything to Medicare rates and things happen for reasons unrelated to Vermont's healthcare delivery system, with Medicare rates at the federal level, we may not want to have pegged reimbursement rates in Vermont to the federal Medicare rates, but it at least provides a benchmark to start with, and there can be a parallel set of rates based on those. Directs the board to begin implementing reference-based pricing by establishing the amounts that health insurers in this state shall pay to Vermont hospitals during hospital fiscal year 2026. So that starts in October of 2025 and runs through September of 2026. So that's where we're starting in 2025, but we're dealing with hospital fiscal year 2026. For services delivered to individuals covered by the health insurer's health insurance plans. So the board will begin implementing reference-based pricing for health insurers, commercial health insurers, for rates paid to Vermont hospitals. The board, in consultation with the Blueprint for Health and other state agencies as appropriate, shall also implement reference-based pricing for non-hospital services and may increase or decrease the percentage of Medicare or another benchmark as appropriate, first to enhance access to primary care and later for alignment with the healthcare delivery plan, statewide healthcare delivery plan established pursuant to section 9403. And it allows the board to enter into contracts as needed for initial implementation of reference-based pricing pursuant to this subsection.
So just to explain that piece, so the board is asking for staff and resources in order to carry out the work in the reference-based pricing section. And so they may not have the expertise initially. They may need to contract out with someone or an individual or an organization that does have expertise. So this provides for that.
Okay. All right. Section 3 gets into some of the hospital budget review statutes. The first one is 18 VSA section 9454. And that is the hospital's duties with respect to the hospital budget review process. So in addition to other items that are required to, information they're required to file with the board as part of the hospital budget review process, this would add the number of employees of the hospital whose duties are primarily administrative in nature as defined by the board, and the number of employees whose duties primarily involve delivering healthcare services directly to hospital patients, as well as information regarding base salaries and total compensation for the hospital's executive and clinical leadership and for its employees who deliver health services directly to hospital patients. It also directs all hospitals to use a uniform system of accounts identified by the board to allow the board to directly compare hospital expenses across the healthcare system. And it just letters an existing provision. Section 4 is hospital budget review, the budget review process. There's a number of changes here that many of them reflect other provisions that are being added in the bill. So in the board's hospital budget review process, it directs the board to review hospitals' proposed budgets based on the information provided. And this adds language about the board requiring hospitals to use a uniform system of accounts to allow the board to directly compare hospital expenses across the healthcare system. The previous section was talking to hospitals. In this case, we're talking to the board. In conjunction with budget reviews, the board does many things. So this is sort of a combination of existing law and new language. Under existing law, review utilization information. This would add, consider the statewide healthcare delivery plan developed pursuant to section 9403, which you'll see coming up, including the total cost of care targets, and consult with the Agency of Human Services to ensure compliance with federal requirements regarding Medicare and Medicaid. As existing requirements to consider the health resource allocation plan, the expenditure analysis, and reports from any professional review organizations. New provision for a hospital that operates within a hospital network, review the hospital network's financial operations as they relate to the budget of the individual hospital. New language, develop incentives for hospitals to support community-based, independent, and non-hospital providers, including mental health and substance use disorder treatment providers, primary care providers, long-term care providers, and physical therapists, services provided through the Blueprint for Health, Choices for Care, and SASH, investments in the healthcare workforce, and other non-hospital aspects of Vermont's health and human services systems that affect population health outcomes, including the social drivers of health. And then I've renumbered. And we have some new provisions coming in at the end here. So under the existing law, the board is directed to consider salaries for the hospital's executive and clinical leadership and salary spread, including a comparison of median salaries to the medians of northern New England states. This adds and a comparison of the base salaries and total compensation for the hospital's executive and clinical leadership with those of the hospital's lowest paid employees who deliver healthcare services directly to hospital patients, and consider the number of employees at the hospital whose duties are primarily administrative in nature as defined by the board, compared with the number of employees whose duties primarily involve delivering healthcare services directly to hospital patients, as well as national average staffing ratios for hospitals of a similar size and with a similar number of locations, and industry best practices for those hospital staffing ratios. For individual hospital budgets established under this section, they must, as under existing law, be consistent with the health resource allocation plan, but I've added be consistent with the statewide healthcare delivery plan, including the total cost of care targets. Also added reflect the reference-based prices established by the board pursuant to that previous section we looked at. That's it for new provisions there. In subsection D, subdivision D1, I've split it out with the existing language being subdivision A about the timing of the budgets. Although as we looked at the Green Mountain Care Board bill yesterday, there were some proposals to modify the timing for reflect the timing for the psychiatric hospital. So that may get its own additional changes. But new language here, beginning in hospital fiscal year 2028, the board shall establish global hospital budgets for not fewer than 5 Vermont hospitals that are not critical access hospitals. And not later than hospital fiscal year 2030, the board would establish global hospital budgets for all Vermont hospitals. We have new language directing the board to establish outcome measurements to ensure that hospital costs are appropriate, that quality and access are maintained or improved, and that hospitals implement their budget orders in a manner that is consistent with the statewide healthcare delivery plan. It also requires that a hospital that proposes to reduce or eliminate any service in order to comply with a budget established under this section must provide a notice of intent to the board, the Agency of Human Services, the Office of the Healthcare Advocate, and the members of the General Assembly who represent the hospital service area, not less than 90 days prior to the proposed reduction or elimination. And it directs the board to evaluate the proposed reduction or elimination for consistency with hospital transformation efforts pursuant to Act 167, the statewide healthcare delivery plan once established, and the needs of the community served by the hospital, and may modify the board's budget or take such additional actions as the board deems appropriate to preserve access to necessary services. Language also directs the board, in collaboration with the Department of Financial Regulation, to monitor the implementation of any authorized decrease in hospital services to ensure that it results in either a commensurate decrease in health insurance premiums or in investments that support primary care and population health, which may include social drivers of health.
That we gotta change there.
Okay. Section 5 is a new section on hospital network financial operations. It says that in order to protect the public interest, the board may, on its own initiative, investigate the financial operations of any hospital network that derives 50% or more of its operating revenue from Vermont hospitals. And the board may take appropriate action as necessary to correct a hospital network's operations that are inconsistent with the principles for healthcare reform established in Section 9371 of this title. Those are the Act 48 principles. All right, now we're moving on to the statewide healthcare delivery plan and the advisory committee. Section 6 is the statewide healthcare delivery plan. This language directs the Green Mountain Care Board and the Agency of Human Services in collaboration with the Department of Financial Regulation, the Vermont Program for Quality of Healthcare, the Healthcare Delivery Advisory Committee established in the next section, and other interested stakeholders to jointly lead development of an integrated statewide healthcare delivery plan as set forth in this section. The plan shall align with the principles for healthcare reform in section 9371, ensure access to high quality, cost effective acute care, primary care, chronic care, long-term care, and hospital-based, independent, and community-based services across Vermont. Ensure that mental health services, substance use disorder treatment services, emergency medical services, non-emergency medical services, and non-medical services and supports are available in each region of Vermont. Provide annual targets for the total cost of care across Vermont's healthcare system and include reasonable annual cost growth rates that will bring hospital and total healthcare spending in Vermont to at or below national growth rates of gross domestic product, and that will bring Vermont's total healthcare spending into alignment with or better than the US average, adjusting as necessary to address Vermont's demographics and rural nature. Using these total cost of care targets, the plan shall identify appropriate allocations of healthcare resources and services across the state that balance quality, access, and cost containment. Says the plan shall also establish targets for the percentages of overall healthcare spending that should reflect spending on primary care services, including mental health services, and preventive care services, which targets shall be aligned with the total cost of care targets. Plan will build on data and information from a number of sources: the transformation planning resulting from Act 167, the expenditure analysis and healthcare spending estimate the board develops under existing law, the state health improvement plan adopted by the Department of Health under existing law, the health resource allocation plan published by the Green Mountain Care Board in accordance with existing law, hospitals, community health needs assessments and strategic planning, also from existing law, hospital and ambulatory surgical center quality information published by the Department of Health pursuant to existing law, the statewide quality assurance program maintained by the Vermont Program for Quality Healthcare pursuant to existing law, and such additional sources of data information as the board, agency, and department deem appropriate. Has the plan identify gaps in care, as well as circumstances in which service closures or consolidations could result in improvements in quality, access, and affordability, opportunities to reduce administrative burdens, such as complexities in contracting and payment terms and duplicative quality reporting requirements, and identify federal, state, and other barriers to achieving the plan's goals, and to the extent feasible, how those barriers could be removed or mitigated. It directs the board to contribute data and expertise related to its regulatory duties and its Act 167 efforts, and the Agency of Human Services to contribute data and expertise related to its role as the state Medicaid agency, its work with community-based providers, and its Act 167 efforts. Directs the board to provide administrative, technical, and legal assistance for development of the plan. And then it spells out a process. So from 2025 through 2027, the board and the agency must engage with stakeholders, collect and analyze data, gather information obtained through the processes established in Act 167, and solicit input from the public. In 2028, they will prepare the plan. And by January 15th of 2029, they will present the plan to this committee and to your House counterparts. And it requires the board and the agency to prepare an updated plan every 3 years and present it to the General Assembly on or before January 15th of the third year after 2029. Section 7 is the Healthcare Delivery Advisory Committee. It creates the Healthcare Delivery Advisory Committee to evaluate and monitor the performance of Vermont's healthcare system and its impacts on population health outcomes, collaborate with the Green Mountain Care Board, Agency of Human Services, Department of Financial Regulation, and other interested stakeholders in developing and maintaining the statewide healthcare delivery plan, and advise the Green Mountain Care Board on the design and implementation of an ongoing evaluation process to continuously monitor current performance in healthcare delivery system. Oh, and then I have another one, so my hand needs to move. Provide coordinated and consensus recommendations to the General Assembly on issues related to healthcare delivery and population health. It has the advisory committee composed of 11 members, the chair of the Green Mountain Care Board or designee, the director of healthcare reform in the Agency of Human Services, and then it has 3 members each that are representing some combination that this committee can decide who you want appointing which of healthcare providers, including primary care providers and community-based providers, healthcare facilities, health insurers, and patients and consumers. So 3 appointed by the Speaker of the House, 3 appointed by the Committee on Committees, and 3 appointed by the Governor. It has the chair of the Green Mountain Care Board or designee and the Director of Healthcare Reform jointly or co-chairing the committee, and it has the board providing staff assistance. Then we get to data integration. This has the Agency of Human Services collaborate with healthcare providers, payers, and the Vermont Program for Quality in Healthcare in developing an integrated system of clinical and claims data in order to improve patient, provider, and payer access to relevant information and reduce administrative burdens on providers. It requires the agency's process to align with the statewide health information technology plan established pursuant to existing law, build on the agency's experience in developing and implementing the unified health data space, which is what they presented to you in here, largely around Medicaid, to include additional payers, and utilize the expertise of the Health Information Exchange Steering Committee, incorporate best practices for privacy and security standards, determine how best to incorporate data from BCures, the all-payer claims database, and data regarding social drivers of health and health-related social needs, establish the steps necessary to enable interoperability of electronic health record systems between providers, identify the resources necessary to complete data linkages for clinical and research usage, establish a timeline for setup and access to the integrated system, develop and implement a system that ensures rapid access for patients, providers, and payers, and identify additional opportunities for future development, including interoperability for emergency medical services providers and linkages between state agencies and federal nutrition programs such as the WIC program. It requires the agency to provide access to data to state agencies and healthcare providers as needed to support the goals of the statewide healthcare delivery plan. This is a new section in session law on retaining accountable care organization capabilities. This directs the Green Mountain Care Board and the Blueprint for Health to jointly explore opportunities to retain capabilities developed by or on behalf of a certified accountable care organization that were funded in whole or in part using state or federal monies or both, and that have the potential to make beneficial contributions to Vermont's healthcare systems such as capabilities related to comprehensive payment reform and electronic health records. And by November 15th, the board and the Blueprint will report to the Health Reform Oversight Committee with their findings and recommendations. Finally, last couple of sections, positions and appropriations. This establishes 5 new permanent positions to be determined whether they will be exempt or classified and what the position titles will be at the Green Mountain Care Board in fiscal year 2026. And these positions will be transferred and converted from existing vacant positions in the executive branch. It adds legislative intent to authorize the establishment of an additional 5 new permanent positions at the board in fiscal year 27 and another 5 in fiscal year 28. We get to some appropriations. Bill appropriates $500,000 from the general fund to the Agency of Human Services in fiscal year 2026 for use as follows: $250,000 for grants to hospitals as needed for transformation efforts related to the Act 167 work and to transition their systems to implement reference-based pricing. $50,000 for expenses associated with development of the statewide healthcare delivery plan, and $200,000 for contracts for consultants and other expenses associated with implementation of this act. It also appropriates an additional $250,000 to the Agency of Human Services, this coming from the Health IT Fund in fiscal year 26 for grants to healthcare providers for data integration in accordance with Section 8. And then it appropriates a total of $1.3 million from the general fund to the Green Mountain Care Board in fiscal year 2026. $750,000 for the 5 new positions, $50,000 for contracts, including contracts for assistance with implementing reference-based pricing, and $50,000 for expenses associated with development of the statewide healthcare delivery plan. Finally, we have the effective dates, and at least for initial purposes, I've made everything effective on passage except the pieces that have cost, which are for the positions and money, which would take effect at the beginning of the fiscal year.
Thank you, Jen.
You're welcome.
Well done, and you did it with alacrity.
You're not allowed to.
I am.
And the chair's
Absolutely am. Yes, exactly. Do you all have any questions for Jen?
Well, it may get thicker as we go, but
Wow, that was great. I have that you're on for S20,
I'm on for all kinds of things.
but
What do you
not
want to do?
until 9:30, so.
Yes, maybe people who want to.
Do you have any markup plan for that already?
Yeah, I mean, yes, there's a new draft. With lots of changes in it that we'll go over, but I think
I'm happy to start now.
the plan is to do it at 9:30 because that's when people are expecting to.
Yeah.
come in.
Exactly.
I'm gonna look at my time.
You want to go?
Have a little break. Senator Cummings, did you have any questions?
No, I didn't get a chance to read it.
Okay.
Switching gears from education.
Oh, okay.
I was in the governor's office, so.
Oh,